Thank you so much, Peter. And good early afternoon, everyone. Welcome to Let's Talk About Health. Let's Talk About Health is presented by the University of Maryland Medical Systems, Community Outreach, and Community Health teams. And we're so glad to have everyone joining us here today. As Peter said, I am Donna Jacobs, and I will moderate today's program. Let's Talk About Health is designed to do several things, but most important amongst them is to give people information and an understanding about key and important health issues, to provide people with information that can help them improve and maintain their health moving forward, and then thirdly, to improve communication between patients and providers. We know it can sometimes be difficult to glean and get all the information that you may get when you're confronting a health issue. Today's topic is chronic kidney disease. Kidney disease involves the loss of the kidney's ability to remove waste and excess fluid from the body, and it can sometimes lead to other serious health complications as well. Here to talk to us today about kidney disease is Dr. Angul Onder. She specializes in kidney and pancreatic disease. She's on faculty at the University of Maryland, Baltimore. She completed her medical degree in Turkey and then pursued her internal medicine training both in Turkey and in the United States at illustrious universities that include the University of Istanbul, Orlando Regional Medical Center, and West Virginia University. She completed her training in kidney and pancreatic transplant surgery at the University of Miami. And she completed a nephrology fellowship back at the West Virginia University. She's also been on faculty at West Virginia and the University of Tennessee in Memphis. And of course, now she's here at the University of Maryland. A few things to keep in mind, as Peter said, this will be recorded today, and we'll be able to give you information toward the end as to how you can see the recording again and see the slides. You don't have to necessarily take notes furiously. Let's Talk About Health, also Peter mentioned, it's intended to be a conversation. Therefore, if you have any questions, feel free to type your questions in the Q&A box, and Dr. Onder is happy to address as many questions as we have time to address. She will not, of course, be able to address individual medical situations or provide diagnoses, but please do feel free to ask general questions, and she's happy to give you that. Again, we are being recorded, and I'll share information at the end as to how you can get that recording, amongst others. We do cast all of these sessions in the context of what's called the Ask Me 3 model. And you see that slide here before you. It's 3 simple questions that really can help you have a bucket, really, to retain the information that you're getting and to understand a problem that you may be having. 3 questions. What is my main problem? What's the problem? What do I need to do about it? And why is it important for me to do this? We're really fortunate that Dr. Onder has several examples that show you how Ask Me 3 can work. And they're also very great for providing additional information as she gives her talk. So with that, I think we'll turn over to you, Dr. Onder, and you have the floor. Thank you so much for doing this.
Thank you, Donna. Thanks for having me here today. So I will love to give that talk today to communicate with more people today. So it is very important to know what is my main problem. That's what I hear from my patients when they come and see me. Usually they don't know what they have, why they are seeing me, and they tell me that, I don't know, my doctor sent me to you. Why do I need to see you? And I introduce myself as I'm a kidney doctor, a nephrologist, and I see patients with kidney disease. And then I see the fear on their face when they hear that. Do I have a kidney disease? Sometimes they are told, sometimes they're not explained or to understood what's going on. And it's difficult, and they know a lot of people around them. They have this problem, and then the fear, takes the play most of the time. And there's always this defense mechanism that they tell me that I feel fine, I urinate okay, so why do I have to have the kidney disease? How do you know I have kidney disease? And then all these questions then comes after that. They ask me that what are the signs of the kidney disease? And then what am I going to do? How do I reverse my kidney function? And how do I get it better? How it's going to be normal again? And what is chronic kidney disease? And chronic usually make people to fear that that word is also scary for most of them. So we have acute kidney injury and chronic kidney injury. Acute is something that can reverse, go back. When you say the chronic, it's usually a persistent finding. So that could be scary at times. And then they ask me that how am I going to stop the progression of the kidney disease, or do I need a kidney transplant, and what do I do from now? Do I have to go on dialysis? So we are going to answer all these questions. Another question that I get, I have 2 kidneys, so the both are affected from that disease, or is it just only one kidney is not doing the job? So most of the people, they have 2 kidneys in their back area. So get the blood supply from the big artery that comes from the heart, supplies the kidney. So when we eat to feed ourselves, the food will be metabolized and then digested, and then the waste products from the food will go to the circulation, and then will go to the kidneys, and then it will be cleared. So the kidneys filtering part is located on that mid part in here that has tons of vessels in here that works crazy, and then clear all these waste products and the urine, and then urine will come with those pipes to the bladder. So these are the ureters, and it comes to the bladder, and then it comes out in both men and women. And when we have a chronic kidney disease, usually it's a systemic disease. It will affect both kidneys. Some people may born with just one kidney, and they may still have normal kidney function with that one kidney. They just accidentally find out that they have one kidney. When they get a transplant, usually transplanted kidney is placed to the either right lower abdominal area or left lower abdominal area. And if somebody gets one transplant, if that fails, they can get the second one to the other side. It depends which side of the kidney was removed from the donor, and then if the vessels are appropriate to place the kidney in there. Usually the original kidneys will stay where they are, unless if there is an indication to remove those kidneys. And that the transplanted kidney, when it comes, they attach these arteries and vessels to the arteries and vessels to the patient, and that ureter comes, and then that's attached to the bladder in here, and then these kidneys will take all the job that these 2 were doing, and then tries to clear the waste products and makes the urine, and then works and then functions. What is the definition of chronic kidney disease? What markers that we use? How do we know that you have kidney disease? You tell me that I'm urinating okay, so I don't have any symptoms or signs. Why do you think that I have kidney disease? So we do a blood test and check your kidney function. When you get lab results from your primary care provider or your healthcare provider, you will see an estimated glomerular filtration rate. It's usually printed as eGFR. That's your kidney function that was calculated with a blood test. And if that number is less than 60 ml per minute, we usually make it simply say that 60% on at least 2 different occasions, 90 days apart, like persistent for 3 months, that you have elevated creatinine level and decreased kidney function. That is a definition of chronic kidney disease. And how do we measure that? With a blood test or a urine test. Blood test is called serum creatinine level. So that's the most common test that we use to measure the kidney function. Sometimes it may not be reliable in some patients, and then we have to use the cystatin C test. That's a new test that has been used in patients that they are malnourished or if they have the large muscle mass. And if there is any abnormal amount of the protein in the urine. Normally spilling the protein is not a normal thing in the urine. It's called proteinuria or protein in the urine or albumin in the urine. Albumin is the medical term for the protein. If it's the tiny albumin or tiny protein, we call it microalbumin. So usually diabetes-related diabetic kidney disease starts with the albumin in the urine before the kidney function will go down. And some of the kidney diseases that you may have normal eGFR kidney function, but you may have protein or albumin in the urine that will be abnormal. And if it's again persistent for more than 3 months, that's called chronic kidney disease. Not just having the decreased kidney function or abnormal protein in the urine, but sometimes having blood in the urine can be abnormal. Not just seeing the blood, like urinating either cranberry juice like urine or Coca-Cola colored urine. That could be related to other things other than the kidney function. So it could be, for example, if you have a kidney stone, that may cause the blood in the urine. But microscopic, or again, just seeing the gross blood in the urine, or if you're not seeing the gross blood, your urine looks all right, but when we do the urine test, if we see red cells, blood cells in the urine, that could be a sign of the kidney disease, some specific kidney diseases, and that would be abnormal to see it. And then the last thing is the structures of the kidneys. That's important to know that because polycystic kidney disease is a very common hereditary kidney disease. It's the structure of the kidneys are abnormal. There are tons of cysts in both kidneys, and you can see the eGFR normal for years, despite that somebody has polycystic kidney disease. Obstruction, it could be related to enlarged prostate or something that blocking that pipes that comes from the kidneys, or when we are urinating, that the urethra that comes out from the bladder, if there's any obstruction in there, it is causing the damage in the kidney structures and filtering part of the kidneys, that may cause the chronic kidney disease as well. So what is called chronic, after we define the chronic kidney disease, then we have a classification system. So what stage of the chronic kidney disease that I have? That's what the patients are usually asking. And as a nephrologist, as a kidney doctor, I usually see when the kidney function is less than 60 ml per minute. When we are born with the kidney function of 120 ml per minute. And when we get older with the age, our kidneys get age as well. And then that function will go down. When you or a 70, 75-year-old person, normally, yes, your GFR will go down around 75. That would be a normal for a 75 probably, but lower than that would be abnormal, lower kidney function. In here, even though it says normal, that's the GFR is normal, but again, if you have excessive amount of protein in here, if you are spilling out blood in the urine, or if you have abnormal structures of the kidneys, it's still called stage 2 and stage 1 kidney disease. So the stage 3, between the 60 to 30% of the kidney function in here, that's the stage 3. I usually see patients at that stage. I hope to see them at that stage to start talking about the delay the progression of the kidney disease. When it goes below 30%, between 30 and 15%, that's one step before the end stage kidney failure. Less than 15% for more than 3 months with the signs and symptoms of the kidney disease called end stage kidney disease. That will require either transplant or dialysis in order to survive. Usually kidney disease doesn't have much of the signs or symptoms all these stages. Usually when you have the advanced kidney stages, that you will start having more symptoms. Very non-specific symptoms like, decreased concentration and itching, dry skin, headache. The things that usually related to what caused the kidney failure will give you the symptoms. And the polycystic kidney disease we start seeing the cyst in the kidneys. Even it can be seen when the baby is in the mother belly, that the baby may start making the cyst in here. And then when you have a lot of cysts in the kidneys, kidney sizes starts growing, growing, and growing. So the bigger the kidney, the risk of the kidney failure is the faster and higher. So, but when you look at the kidney function, eGFR, even though patient has cysts, a lot of cysts in here, kidney function is still normal. It just started dropping after a period of time in here, but a really fast drop in the kidney function. So that's why it's important to know that if there is any family history of kidney disease, if there's any polycystic kidney disease, so they can be diagnosed earlier in here because they will have some symptoms like urinating at nighttime or high blood pressure or polycystic kidney disease complications that they have it. So it's very important to start these people on blood pressure medication and specific treatment for the polycystic kidney disease even before their GFR drops. So I'm not going to see these patients in here unless if somebody knows that patient history, family history of the kidney disease, and if somebody is aware of that there are medications are available to try to reduce the size of the cyst and the progression of the cyst growth. So that is important to delay the progression of the kidney disease. Now, when we come to the stages, chronic kidney disease is classified based on the kidney function and the protein in the urine. So these are the stages of the kidney disease. Now they have a new classification. We have 5 stages of kidney disease, 1, 2, 3A, 3B, 4, and 5. 5, when patient needs dialysis or transplant. 4, 1 step before dialysis or transplant. 3B, it's really coming closer to 4. 3A at the beginning of the mild to moderate kidney disease. And we can still see stage 2 and 1 with the kidney function greater than 60, but like polycystic kidney disease or transplant kidney made with the one kidney that may have kidney function greater than 60, but may have problems and blood in the urine. So the albumin or protein in the urine, this is normal, this is moderate, this is severe. So the more the protein in the urine, the risk of the complications are higher. The more decrease the kidney function, then risk of complications are higher. Risk of complications mean kidney failure, that, cardiovascular disease, and stroke, heart attack, and all kind of things. Risk will increase with chronic kidney disease. Chronic kidney disease itself is a risk for the cardiovascular, stroke, and heart attack, and death from these results or the sickness from these conditions. It's a non-traditional risk factor. Like the traditional risk factor, for example, diabetes, for the stroke and heart attack, right? Well, the diabetes is most common cause of the kidney failure. So we have over 34 million people in the United States with diabetes, and our number one reason for kidney failure or chronic kidney disease is diabetes. And the second more common, or they can go head to head, is the high blood pressure, hypertension. Well, nearly half of adults in the United States has high blood pressure. So these two will make most of the chronic kidney disease patients. Patients may have symptoms related to diabetes, high blood pressure, and then they may have chronic kidney disease if they have persistent abnormal kidney function test. The other risk factors are autoimmune diseases. For example, lupus. Lupus is a very common autoimmune disease, or sometimes rheumatoid arthritis can cause that also, and some other autoimmune diseases can cause kidney disease and kidney failure. Hereditary kidney disease is very important to get the family history of it. Ask your aunts, uncles, cousins, grandparents if anybody had kidney disease. Of course, if they were not screened, they wouldn't know if they had kidney disease. It is really difficult to get the family history from the patients, the correct history. But two hereditary kidney diseases are very, very common diseases. For example, that polycystic kidney disease, the prevalence of the incidence of the polycystic kidney disease is more common than combination of the sickle cell disease, Down syndrome, cystic fibrosis, Huntington disease, that all this genetic disease that you can list. Polycystic kidney disease is more common than that. And it doesn't spare the race, gender, or population. It's all over the world. It is one of the most common hereditary kidney disease. Another one is APOL1 gene disease. That gene problem will protect people from some infectious diseases, but it will prompt them to have either high blood pressure or chronic kidney disease. In a dialysis unit, if I have 10 patients with high blood pressure, probably 5 of them has that mutation and they're not aware of that. It becomes important when they need a kidney transplant, because their family members need to be screened for that. You don't want to take the kidney from a person that may have potential polycystic kidney disease or APOL1 gene mutation. So they need to go through the screening to make sure that it's okay for them to donate the kidney. And the other cause of the chronic kidney disease could be the structural abnormalities that we usually see in children. With the recurrent urinary tract infection or abnormalities in the urinary tract or obstruction of the kidneys in adults, usually, ovarian cancer in females or prostate issues with men that may cause obstruction and kidney failure. Nephrotoxins are becoming a big part of the kidney problem, may cause acute kidney injury and, repeated exposures. And if you have underlying other problems that with the mild chronic kidney disease, on top of that, when you're exposed to something that's toxic to the kidneys, such as drugs, for example, non-steroidal anti-inflammatory drug users, right? You can see it in the commercials. That's great for the osteoarthritis pain. Yes, it's great, but for the long-term use, and if you are at risk for chronic kidney disease, having those conditions like diabetes and hypertension, then you got to check your kidney function to make sure that it's not harming your kidneys. These are big, and I see a lot of patients that when you just stop the non-steroidal anti-inflammatory drugs, you can reverse some, or just stop the progression of the kidney disease. Antibiotics are big, specifically with diabetic patients with the wounds when they have bone infection. So they will expose the antibiotics. Some of them are life-saving. There's a risk and benefit calculation in there, but some of them might be toxic to the kidneys. Intoxications are another group of things that may cause kidney disease. HIV itself was causing significant damage in the kidney. With the medication, we don't see that most of the time HIV-related kidney disease, but the medications can be affecting the kidney function as well. And having the hepatitis C or hepatitis B along with the HIV may cause different types of kidney disease. Just a regular bacterial infections, again, if it's causing really severe sickness in patients, that may cause kidney disease as well. This is very important: socioeconomic risk factors, lifestyle, obesity, tobacco, alcohol, and drug use, because these are all just linked to each other, and the patient goes into a vicious cycle with that. Obesity will cause high blood pressure, diabetes, and then chronic kidney disease. And on the top of that, if the other contributors are on board, of course, kidneys will get affected from that. And it's an important thing to know and to try to, make everything as healthier as possible under the circumstances. This is really important to give the education and try to prevent the disease is more important than try to fight with the disease. So if you look at the epidemiology of the chronic kidney disease from 2022, when they looked at in 2017, worldwide, there was over 843 million people with chronic kidney disease. So that's a really, really big pandemic. It is a crazy number. 1 in 10 people has chronic kidney disease. Who are at risk? People with diabetes, racial minorities, old people, women, and people with high blood pressure. Well, having it is a big problem because it's a cause of death, and it is ranking higher as a cause of death for the years ahead. And in 2040, it is estimated that chronic kidney disease is going to be the 5th common cause of the death for people. And how many people that we have with chronic kidney disease in the United States? Around 37 million. So it's almost equal the number of the diabetic patients. More than 1 in 7 people have chronic kidney disease. What is really scary about that? Only 10% of patients know that they have chronic kidney disease. That makes 3.7 million. 4 million knows, and 33 million people, they don't even know that they have chronic kidney disease. And of course, the cost of Medicare, that's the worry for the government. And it's a problem for government, it's a problem for us as well. So if you're gonna tell me that if there's not much of the symptoms at the beginning and it's important to early diagnose it, then how do I know if I have chronic kidney disease or not? So you gotta know your risk factors, because chronic kidney disease is a silent epidemic. Again, 34 million people, they don't know it. 3 to 4 million people, they know that they have it. So what are the risk factors that you gotta know? That high blood pressure, diabetes is a risk factor. Then if you have high blood pressure, diabetes, then when you go and see your doctor, and you're going to be aware of that, okay, diabetes can cause kidney disease, high blood pressure can cause kidney disease, and if I have a family member with kidney disease, I may be at risk for the kidney disease. So when you see your primary care doctor or your healthcare provider, you ask them, do I have a kidney disease? How do I get tested for that? What is my creatinine? Do I have any problem in my urine test? And with whatever that information is available, and then further tests needs to be done. Let's say that you have high blood pressure or diabetes, but you are tested for that and you didn't have chronic kidney disease, but still you have existing risk factors. So there's a need to continue monitor for chronic kidney disease and with the blood and the urine test. And you gotta talk to your doctor how often that you need to be screened for that. Why is it important for you to do that? Because it is a leading cause of kidney failure and death. It's important, and it's an increasing risk factor for the death, and it's going to be the 5th common cause of that in 2040. So how are we going to diagnose it? As I told you, blood test. It's a simple blood test is drawn, blood creatinine level and or cystatin C level to confirm it sometimes, and urine test for albumin and protein. You don't have to do the 24-hour urine most of the time. Just the random urine specimen could be enough for that testing, and usually your primary care provider will provide that to you. Kidney imaging is important if you have history of polycystic kidney disease specifically. Even if your kidney function is normal, your blood test, urine test is normal, you may still need to get the kidney imaging studies up to age of 30, 40s with the different intervals that require to have the imaging study done. If there is any problem, then you're going to need to see a kidney doctor. And if it's indicated, kidney doctor may or may not suggest you to have a kidney biopsy done. If there is an identifiable reason for the kidney disease, then you may not need to have a kidney biopsy done. In some certain conditions, for example, lupus, autoimmune diseases, that will require a kidney biopsy in order to get the right treatment and reverse the inflammation in the kidney. Kidney ultrasound is a simple test. You're awake and they're just going to put some gel in here and put that probe in here and get your kidneys pictures, and then read the structures of the kidneys and send a report to your doctor. Kidney biopsy is usually outpatient procedure and usually doesn't require any sedation or anything, unless if you're a very anxious person. They will do it with the local anesthesia. You lie down to your stomach. They will check with the ultrasound or the CT scan, put a needle in and get specimen and send it to the pathology, and now we will read that what caused the kidney problem, if there is something that is treatable or not with some kind of medications that is necessary specifically for lupus-related kidney diseases. So once we establish the kidney disease, we identify the risk factors and we know that there is a kidney damage. And then what are we going to do now? What's the next plan for that? When we come advanced kidney disease, what are we going to plan for dialysis, transplant, or other referrals? So the lifestyle changes, healthy eating, physical activity, and exercise, and try to maintain the weight, avoid the obesity, and avoiding the all bad habits are the gold standard to prevent everything: diabetes, high blood pressure, including kidney disease and heart disease and stroke. In our part, in chronic kidney disease, specifically salt is important because our diet is full of salt. I hear from my patients that I'm not adding salt. It's not just adding the salt. Food comes with salt. Need to read the labels, that how much sodium, salt in every food that you get throughout the day, and calculate your sodium intake. That is very important when you have chronic kidney disease, because salt will cause fluid retention and it will cause difficult control blood pressure readings. And when you limit the salt, then that will help to control your blood pressures better. That will control the fluid retention better. And need to see the dietitian for the right amount and the source of the protein as well. For the protein restriction, we can do more details on the Q&A, but salt is number one thing that we want to really reduce in the diet with the chronic kidney disease. When you know that you have problems, that's even when you don't have any problems, these are the things to do. Avoid the smoking, excessive alcohol, not necessarily, don't take unnecessary non-steroidal anti-inflammatory drugs. Some antibiotics that has to be discussed with your kidney function needs to be checked before you get started on antibiotics that may be harmful for your kidneys. And there are some special precautions needs to be taken place. For example, colonoscopies or heart catheterization. If you have underlying chronic kidney disease, then you may get some recommendation from your kidney doctor or your healthcare provider, which medications needs to be had and what kind of fluids that they should give you throughout the procedure to help for your kidneys. And of course, there's medicines to slow down the progression of the kidney disease. And when there is kidney damage, reduced kidney function, now we have a little bit more problem other than what was causing the kidney problem. So before here, we had diabetes, high blood pressure, other things that were causing kidney problem. We have to treat the underlying risk factors. But when we have kidney damage, kidney is not only in charge to produce water, to make you pee, or get rid of the waste products, but they also in charge to make hormones. So they regulate your bone marrow to control your blood count, and then it controls the parathyroid hormone level to control your bone health. So people may get metabolic bone disease from chronic kidney disease. I will call it like osteoporosis of kidneys, because it will change the hormone levels. The kidneys are in charge to activate the vitamin D, and when that doesn't happen, and then we have glands in our neck that will produce excessive amount of the parathyroid hormone level. And kidneys makes erythropoietin. That's the hormone that will help to produce the red cells. And if there's a decreased kidney function, so there won't be enough erythropoietin, and it will kind of reduce the iron absorption from the gut as well. And then people with chronic kidney disease may get anemia and metabolic bone disease, and they may require treatment for these things as well. But diet is the most important thing, but it's not the only thing to maintain your health. Yes, there needs to be right amount of sugar, right amount of carbs, right amount of calorie intake, right amount of salt intake, right amount and the type of fat intake, and right amount of protein intake. That's really important to follow, but we also need medications. So I always hear that I'm on so many medications, and I hear you, and I, as a doctor, I hate to take medications. I don't even like to take one medication, but unfortunately, that's a condition that you have to control blood pressure, you have to control diabetes, and if you have anemia or bone disease, you have to control them with medications. But we still want the exercise and diet to reduce the amount of the medications to take. And so that's the reason that most of the times chronic kidney disease patients have so many medications. It's difficult to control the blood pressure when you have chronic kidney disease, because kidneys are in charge in a lot of hormones that will affect also your blood pressures. So that hormone levels will go up, and we use a different type of medicines to try to prevent the fluid retention, try to block that hormone and that one and that one, and that requires at least 3 or 4 blood pressure medications sometimes to control the blood pressures. So it can be confusing and difficult to track. So that's why it's important, get a pill box to arrange your medications in advance. You got to take your medications at the same time each day and record it. Yeah, like driving, you got to get that reflex, ready so you don't forget it. And then you have to record it because you may forget that did I take the medicine or not. If you take it again, if you duplicate your blood pressure medicine, that happens a lot. I see sometimes, specifically if there's any cognitive problems or forgetful patients. So if they duplicate the medicine, they take it again, that may harm the kidney function as well. So we don't want that. We want you to take your medicine, but not to duplicate it. To write it down and maybe use an alarm as a reminder, or find a way to be able to get it at the same time. And I would like to see all the medications when I see my patients when they come to clinic, because they take something they forget to say, but that might be harmful for the kidneys. And it's better to bring all your medicine for your kidney doctor to review them to make sure that if they are okay for you to continue to take it or not. Why is it important for you to do that? Because it is very important to control your blood pressures to reduce the risk of stroke and heart attack. And when you have a high blood pressure, if you don't have a monitor at home, you wouldn't know what you're doing. You need to check your blood pressure. So when even you don't have any symptoms. If you have symptoms, you definitely need to check your blood pressures. What if your blood pressure is too low, and if you give yourself a medicine, then it will cause more problems, low blood pressure? What if your blood pressures are not controlled despite that you're taking your blood pressure? So because some patients may need a different type of blood pressure medication to control their blood pressures. So without information, medicine doesn't work. You need some evidence to show your doctor and to discuss with your doctor and see that what is working for you and what is not working. And it is important to improve your anemia. Like if your blood count is low, there might be some medications to use to improve your blood count and for you to feel much better, have more energy to try to keep going on with your life. And control your fluid status is important to avoid the hospitalization. That's why it's important to work with your doctor with your fluid medicines, not to retain the fluid, but not to get dehydrated also. It's a really delicate balance to try to find to avoid the hospitalization. So I get the polycystic kidney disease patients usually after an incidental diagnosis. For example, somebody gets into a car crash and they go to the emergency department, they get a CT scan. Oh, there are big kidneys full of cysts. So they don't know if they had any family members with kidney disease or polycystic kidney disease. So they're kind of surprised, why do I need to see a kidney doctor? Or they told me that I have cysts in my kidneys. As I told you earlier, polycystic kidney disease is one of the most common cause of hereditary kidney failure, and it requires really tight blood pressure control, lower than the other blood pressure goals, that helps to reduce the cyst growth, and it has specific treatment options that you can use and to try to control the progression of the kidney disease. And what do you need to do? You don't have to wait until your kidney function is really low. If you have polycystic kidney disease, you need to have an early referral to the kidney doctor. There is an FDA approved medication. You may be a candidate for that to take it. And there are still ongoing trials for some medications. In the past, it was unfortunate when you have the polycystic kidney disease, you wouldn't want to go and test it. And we had seen a lot of patients, they didn't even get their blood pressures controlled, and had, when you control the blood pressures, you can gain so many years without needing the dialysis on polycystic kidney disease. That is very important to start the early intervention to control the blood pressures and identify the rapidly progressive cases. That means big kidneys. Sometimes these patients will require MRI to get calculate the kidney volume if it's big enough to start a specific treatment that was approved by FDA. What are the symptoms of polycystic kidney disease? Normal kidneys look like that, but the polycystic kidneys can be really big, in a size of a football ball. And of course, it will cause when those cysts are big and kidneys are big and getting the nerves from the back, from your spine, and it may cause pain, flank pain. That's the one of the most common symptoms that a polycystic kidney patient may have. It will cause urinary tract infections. Those cysts may bleed or may get infected. Kidney stones are common in polycystic kidney disease. And of course, the abdominal pain and bloating can be very common. And high blood pressure is one of the first clinical findings that you can see with polycystic kidney disease, other than the nighttime urinating. And reduced kidney function, really, when you get closer to dialysis, that will happen with that. So it's so important to know the family history, and if you have any problems, to deal with that at the earlier stages. So now we have COVID pandemic. As if you paid attention to the numbers, you saw that CKD was way higher than the COVID, right? How we have been scared from the COVID for the last 2 to 3 years, because more than 180 million people got diagnosed within the short period of time. Now we have over 800 million people with chronic kidney disease, and we have 37 million people in the United States with chronic kidney disease. So that's a big problem. And how many people died from the COVID? Nearly 4 million people died. The ones that they had COVID and they got into the hospital because of the severe illness, 28% of them, almost like 1/3 of them, they had some kind of kidney disease. It could be kidney injury related to virus itself, or infection, or medication, or just dehydration. COVID can cause 2 to 3 different mechanisms for the kidney failure. And among that 28% of the patients, 9% of them needed to be on dialysis. What is expected from the COVID, that it may leave some long-term damage, and we may add another 500,000 people with some form of kidney disease as a result of the long COVID infection. Like the kidney failure persists beyond 12 weeks or 3 months after the COVID is resolved. May have a normal creatinine level before the COVID was diagnosed, and if there was a problem with the kidney disease, and if it has been persistent after the COVID resolved 3 months or so, then that will add additional burden. So when patients have end-stage kidney disease, the GFR is less than 15%, and they have been feeling sick because when the kidney numbers get lower, function gets lower, and then symptoms may be more obvious. And most of the patients are really scared. They have either friends or family members. Every patient have a different history. Some they really didn't have a good experience from their family history, and they don't want to be on dialysis, and they are really panicked, and they immediately request a medication to reverse the kidney function. When we come to the end-stage kidney disease, it's beyond the repair. So we have to accept the idea and move on really fast, because what is important is that you have to plan. The storm is there already, and we have to plan. Once reached end-stage kidney disease, there is no medication to reverse the kidney function. We have to decide either in-center hemodialysis, home peritoneal dialysis, kidney transplant, or some patients may say that, I had a wonderful life, I saw everything in my life, and I don't want to be on dialysis, I just want to do the transition in my home with the palliative care. That's patient choice. So what we need to really pay attention is that what comorbidities, other diseases that patient has, what the patient expectations are, what are the eligibilities and the socioeconomic status, and shared decision making is very important between patient and among the patient and the nephrologist. And what is really important also, timely treatment modality decision. So if we decide that we are going to go to the hemodialysis, we need to make the preparation before the things are really, really bad, or for the transplant, we need to make the preparation. So it is important to see a nephrologist at the earlier stages to discuss the dialysis options, transplant options, and to see that what option is more suitable to you, to start making plans. And if you are a candidate for a kidney transplant, it is important to have an early referral. It will require a bunch of testing to be done, and transplant is the best option if you are a candidate for that. And if you're not a candidate for a transplant, then to prepare for dialysis with the best access, dialysis access, to start the dialysis, because these decisions will affect the quality of life and survival in the future. When we get a kidney transplant, as I told you before, the original kidney stays in here. They put a transplanted kidney in here, but that will require immunosuppressive treatment because you're getting somebody else's kidney, unless if you have an identical twin that you're getting the transplant from that, you may not need the immunosuppressive medication. But even if you have a fraternal twin, it's still a foreign organ for you, and you have to take medication. So that requires workup. So, and if you're recommended to get a transplant, then you're going to be evaluated by kidney transplant team. They're going to do blood test, urine test, cardiac workup. They will rule out the chronic infections, cancer, severe heart, lung disease. You have to be in the best shape to get a kidney transplant. Heart should be good, liver should be good. If you have liver failure, then you may need both liver and kidney transplant. If you have heart failure, you may need heart and kidney transplant. That makes things more complicated. And they will review your social supports, your ability to take care of new kidney transplant. You must be very good at taking medications. Like if you're a dialysis patient, if you're not showing up to half of your treatments, transplant team will take that as a non-adherence to treatments. So it's important for them to know that because that's a very precious thing to keep it. It's very difficult to get it, and they don't want to waste that kidney. That is important for you to be able to follow up all the appointments that they are going to give you. And if you have a living donor, a relative, friend, or someone that you know, that person has to go for the workup as well immediately. If you look at the numbers in 2021, over 90,000 people were listed for a kidney transplant, but only 24,000 got it. So when you're listed, that doesn't guarantee you to get a kidney transplant. But if you have a living person in 6 months, if everything is all right, you can get the transplant. But when you're listed for a deceased donor kidney transplant, it may take 2-5 years to get the transplant. So the half of these patients are pediatric patients. So just you see the numbers. They are really, really low, the number of transplants. So if we can't get the transplant, what are we going to do? Our options are hemodialysis or peritoneal dialysis. There are two types of dialysis. But this is important to make that decision, which one that you want to decide to discuss with your kidney doctor in order to have an early referral to the surgeon to get an access placed. That's important to have either fistula or graft placed to avoid the catheters as possible. This is a plastic tube that goes to your heart to do dialysis if you haven't had your fistula or graft surgery done, and if you needed the dialysis immediately. So that's a risk for infection, and we don't want this catheter to stay there more than 3 months because it will just stay on those big vessels. It may cause narrowing in these vessels, and it may reduce the chance of this access to work in the future. That's why it's important to get an early referral to get those done to avoid the catheters as possible. And the peritoneal dialysis, if you're a candidate for that, that is something that you can do it at home. For example, if there's a COVID pandemic, you don't have to go to dialysis unit to do it. You can do it at home. AV fistula will look like that. They will put one needle in here to get the blood out, circulate it through the machine, clean it, and give it back to you. That they just open your skin and then stitch the artery and vein together to create that fistula. If your veins are not so great, then they will put a graft in there that's like a semi-synthetic material that they put under the skin. So if you're not able to get any of that, or you're on the way to get the workup done, but you needed dialysis, then they will put a catheter usually to your chest when you go home to get your dialysis done. That's called hemodialysis catheter. This is peritoneal dialysis catheter for home dialysis. That catheter goes to the belly, and then it just, it has a long tip in here. When we can do either manual exchanges or exchanges on the machine. So that's home hemodialysis. So you can do dialysis, both hemo or peritoneal at home. So he can use his access. If he has a fistula in here, he can put the needles to himself, or he can get his spouse or somebody else to put the needles in and watch him during the treatment. And that's daily, 5-6 days a week, home hemodialysis. If you don't want to do it at home, you can go to a center to get your dialysis done in-center. If you did decide for the peritoneal dialysis, you can do the exchanges even when you are camping outside, but we recommend you do it in a closed environment, like in a car or something, to do these exchanges. You put the fluid in, you disconnect yourself, you go do whatever you want to do. 4 to 6 hours later, you come back, you empty your fluid, and then you put another one, and then you disconnect, and you go and you do whatever you want to do. You can do that when you don't have the power. Like, for example, if there's a hurricane or earthquake or something, that's a type of dialysis that can be done. And if you want to use the machine at home for home peritoneal dialysis, it's a small machine that you connect yourself to machine, you hook yourself to the machine at night, and you wake up in the morning, you disconnect, you're done. That's home peritoneal dialysis. Let's say that you have been on peritoneal dialysis and you're on the waiting list for the deceased donor transplant, but you have a potential living donor, but she wasn't a match for you, but you want to speed up your chance on the waiting list. If you don't have a match with if you have a living donor, that's a great thing. There is a problem with the lack of education. So you can swap your donor with somebody else's donor and get a living, unrelated, kidney transplant. That's very important because when you have a transplant, that's a better chance for survival, better quality of life. And if you are a candidate for a kidney transplant, that is the most important thing to proceed and to try to get the transplant from a living person if it's possible. When you wait on the list, you don't know if you're going to get it or not. There's a waiting time for that. So that's all I have to tell now. Now I'm anxious and waiting for your questions, and then we'll go from there.
That was an amazing amount of information. Clearly, you are passionate about this. And I think this is my own perspective that there are so many other diseases that are spoken about more often. And so to hear you talk about how many people may actually have chronic kidney disease is critically important for us, especially since so many people don't know it. And the interrelationship with diabetes and high blood pressure. That was very, very critical and key information. I thank you. There are just a couple of questions here. When you get a transplant, are they transplanting both kidneys or one, and are they interchangeable? Do you get someone's right kidney to your right side, left kidney to your left side? Or can you take a right kidney and put it on the left side?
It depends on the anatomy. Let me try to remember that which one was going to the which side, because it has to be with the anatomical appearance. I don't know if I can go back to here to show you. There you are. So this is the right kidney, and then right comes to right. Left comes to left. When you try to switch the left, it's kind of difficult anatomically to do the anastomosis. That's like connecting to the vein and artery. So the kidney comes with a vein, with an artery, and with an ureter in here, okay? Mm-hmm. So it's easy to do the right anatomical thing on the right place.
Got it.
Because otherwise, if you try to flip back, then when you put the stitches in here, then it may cause thrombosis, blood clot, and that kind of problems. So they usually don't do that. And then the pipe also comes, and you usually get one kidney, but if you got a deceased donor that was a pediatric case, they have small kidneys, so they may put these two small kidneys to attach to this area, one in here, and the ureters also comes and gets attached to the bladder with the pediatric deceased donor kidney that you can get two. But adults, you get one.
So a listener wrote, Dr. Anda, you spoke about a relatively low rate of living donations. Is that partly because it can be difficult to get qualified as a living donor? I was told that I'm too overweight, 30 pounds, to donate to my father, but otherwise healthy.
One thing is that because you don't have the available donors, but it depends on government policy and procedures. Like in Spain, when you die, your kidney can be used. Doesn't matter if you gave the consent or not. In Iran, the government has policies for the transplant, so they don't get the organ shortage like we get it in the United States. It all depends, really. One shortage, the reason for the shortage is that we are not using everybody's kidneys.
Mm-hmm. Mm-hmm. Okay, so for someone born with only one kidney, can you elaborate on nutrition or food that you eat to keep that single kidney healthy?
So when you have one kidney, born with the one kidney, that tries to work harder to try to compensate. I don't know, for some reason we have two kidneys naturally, but when you get one, or when you had two, if one was removed because of the cancer, and then the remaining kidney try to work harder. So the same thing with the single kidney, same thing with the transplanted kidney. We all call them solitary kidney. So because they work more, what we call is increased filtration. That may cause protein leak. These patients with the one kidney, they need to be monitored if they have protein in their urine. They may need to limit the protein intake in the diet. Try to avoid the excessive amount of the protein. Because they have only one kidney, God forbid, if there's any, accident, like if you get a trauma to that kidney, you don't have another kidney to try to compensate it. So need to really protect that kidney. And you have to consider as like a chronic kidney disease, try to avoid the things that may harm that kidney function. Like don't take ibuprofen, Motrin, Aleve, Advil for regular pain. Tylenol 2 to 3 tablets a day, acetaminophen is okay. But if you're a very thin woman, that you may need to limit your Tylenol intake as well. But definitely for simple pains that can be treated with acetaminophen, would avoid the NSAID use. That's for sure. Try to avoid nephrotoxic or kidney toxic medications or IV contrast, fluid enemas kind of things, dehydration. With single kidney, if they have high blood pressure, they may need to be on certain medications that we call ACE inhibitors or ARBs. If they don't have any problem in their artery, if the artery doesn't have any narrowing, if it's a normal one kidney and spilling some protein, have high blood pressure, they may need to be on kidney protective medications called ACE inhibitors and ARBs.
So we only have 2 minutes and the questions are coming in, so I'm not going to be able to get to all of these. Sodium is something we've heard a lot about in so many of our webinars, our Let's Talk series. Someone says, how much sodium should we take a day? And let me just add, you mentioned NSAIDs a couple of times. How much NSAIDs is too much?
Long-term use is definitely too much, more than 5 days or so.
More than 5 days. Every day.
Every day, yes. Like try to limit it short period of time with excessive amount of water. But if you're on some certain medications, try to not to take the NSAIDs at all. Use the alternative medications. Those, I see that people unnecessarily take excessive amount of NSAIDs. Like you can get away with just 1 pill a day, but they take 3. And 3 times a day. I had seen a lot of people after the exercise, just for the sores and pains, they were taking 3 Advil or Aleve unnecessarily. There's no need for that.
Right.
And then when they stop it, they don't have aches and pains. They were just taken for no reason. That's for the NSAIDs. For the sodium, it depends on the heart failure and other conditions as well. Average number, just for the chronic kidney disease, we recommend average less than 2,400 milligrams per day. But if there's severe heart failure, then that number may go down to less than 2,000 milligram or 1,800 milligram. It depends on the fluid retention.
Okay, we're going to try to go quickly and get through some of these, but I'm going to have to cut them off at some point. What makes somebody a good candidate to do home dialysis? Someone said their dad is frustrated with going in center, but they really can't see them doing it at home. How do you know if you're a good candidate to do it yourself?
If you don't have any, like a colostomy, ileostomy bags or big, so many surgeries in the abdomen, that should be good enough. But even if you have a colostomy or ileostomy, neither they have a different techniques that they can put the catheter up higher to prevent the infection, because the feces can come out and that may infect the catheter. One thing is that you have to have a really nice abdomen without many surgical scars. Like gallbladder appendectomy is okay, but if you had an exploratory laparotomy, it's a big surgery, and if they did so many surgeries, it may not work. But it can be seen by a surgeon to see if it's still okay. Diabetes is not 100% contraindication. If the blood sugars are good control, they can do the home peritoneal dialysis. It is underused. It can be used by many people at home, and it's not difficult to do it. It's easy to learn, and you cannot kill yourself on that. You can kill yourself on the home hemodialysis, but not on the home peritoneal dialysis. The worst case scenario, you will get the infection, but they will educate you, and then you can treat the infection faster.
Dr. Under, okay.
Mm-hmm. Go ahead.
I'm going to take this last question, and then we're going to try to record the other questions that came in. There are 3 or 4 of them, and then answer them later, and I'll tell people about that. So someone says, and I think this has a universal application for many, I'm on the transplant list at Hopkins. Would it be beneficial for me to also get on the transplant list at the medical center? I do know sometimes people get on more than one list. Can you speak to that?
Some centers may have more turnover. So if their insurance is accepting, I usually encourage people to be listed in more places, as long as their insurance is okay with that.
Okay. All right, then I'll squeeze in one more and then we're going to stop. Can you travel with dialysis? How do
Yes,
people
you
do
can
that?
cruise and you can travel. Specifically with the peritoneal dialysis, it's easy. Even with hemodialysis, they have some cruise programs that they can offer that. They have to find out that. But the peritoneal dialysis is easy. You talk with your social worker in the dialysis unit, so they will, send the equipment and everything to do wherever that you're going to travel. But you need to make the plans and give them time to try to arrange everything for you.
All right. All right, we're going to call it off now. And there are a couple of questions we will try to write. If you can go to the slide after your final presentation slide, I can just tell the audience where we are. The next one. Yeah. So if you would like to, go back. If you go back to maybe. If you would like to view this presentation again or see any of the others that have gone before, you can go to www.ums.org/Let's Talk. And all of the presentations are up there, from telehealth to COVID vaccines, and that's going to be dated now, and heart health. Heart health we also did again last month with an emphasis on hypertension and stroke. There's stroke. There are many, many issues up there for you to look at, and you can view them there. Next slide. Next month, again, the third Wednesday in the month. Go to the next slide, please. Our Let's Talk session will be about autism. Many people have asked us about that. So that is on April 19th, 2023. And there are several people who have said, thank you very much, Dr. Onder. I want you to know that. I'm very appreciative of all of your time, everyone, and Dr. Onder most especially appreciative of your time. Have a good afternoon, everyone.
Glad if I had a chance to have more people to hear it. Thank you.
Thank you.